Sam, thanks a lot. That's really exciting. You sort of took some of the thunder out of what I was going to say. I was going to ask, did men feel better when they
Oh,
had testosterone reinfused in them? And you said that they did see some of that, right?
yeah, I think it's interesting. Some men feel a lot better, like they're shot out of a cannon kind of better.
Oh, really?
Certainly giving an 85-year-old man his libido back is an interesting concept because and some of the men, their sexual function returns, but it doesn't happen.
But really, you actually
universal.
saw sexual function return?
Oh yeah, a lot of
Wow.
these men can have sexual activity again, but it doesn't happen to everybody. Some men actually felt worse on the testosterone; they felt more tired. But the majority, I think, we did a lot of quality of life things that we looked at. I think the big ones where that got better were sexual function and physical function, and sort of just this kind of it's almost like their zest for life improved. They started doing more activities, going out more, doing things that they didn't do before, and then it really had a big improvement in fatigue that people felt. So those are the three areas that we saw kind of the biggest.
Really?
Yeah.
It's it sounds like you're going down the path of what we did years ago with intermittent androgen therapy. In a way, with this, you're talking about doing that in the future.
Yeah, so we've done some studies looking at patients who aren't castrate resistant to see if you could do this, because the original idea for intermittent androgen deprivation was not to do it the way we do it. It was to give testosterone in between the cycles. At least that's what they did in the laboratory. Dr. Bukowski, who did those original studies. So we've thought about that, and we've done one study that we published, but our big focus has been on the castrate resistant group, because there we think it's not just an improving quality of life, but it's actually having an anti-tumor effect. In the guys who are hormone naive, it's probably more of a quality of life effect, and maybe prolonging the duration of response to hormone therapy. So we're kind of looking at it in both ways. The hardest part of this is this is a generic treatment, so we haven't really had any pharmaceutical support. We're pretty much doing this through the grant mechanisms, and we've been fortunate enough that we've gotten some nice funding from NIH and the Department of Defense to kind of support this effort.
You mentioned Nick Bukowski, and his work with intermittent androgen deprivation therapy. I think one of the criticisms was that he used the Shionogi mammary tumor model, and it was not. It was a mammary tumor that was based on. But I think it made some sense. And testosterone is a very interesting hormone, as you well know. That Abe Morgenthaler and the Androgen Society just had a 3-day meeting, one of the best meetings I've attended, virtual meeting, a few weeks ago, and it was all around testosterone. I learned a lot.
Yeah, I've been to I've spoken at the meeting, and I've met Abe and talked about this idea. Well, I think it's sort of, it's like an old concept. I mean, if you go back and look at Charles Huggins' his original work, he was the first to propose this idea. So if you look at his Nobel Prize speech, the last paragraph of his speech, he describes 2 ways to treat hormonally responsive cancers: either deprive the hormones or give too much. And he actually went on, this is weird to me because he's a urologist, but he explored this concept in breast cancer, not in prostate cancer. So the first kind of demonstration of this potential back and forth, high and low, was in breast cancer. And I think I'm just sort of re-exploring that concept. So everything that's old is new again, I guess, in terms of.
Yeah, we're sort of circling back. I remember when we were doing retroperitoneal lymph node dissections on young boys and men who had testis cancer after chemotherapy when platinum first came out. and they were really depleted and not doing well in the hospital. Some of them bleomycin, whatever. And John Wetlaufer, who had done a lot of these, the urologist at the University of Colorado, who went up to Madigan and just died a couple of years ago, would give these guys what he called a testosterone lollipop, which he would give them some testosterone. It was amazing how it turned a lot of these guys around, these young kids around.
Yeah, we definitely see a big bang on the bone marrow. So the men, certainly the hemoglobin comes screaming back up. I mean, some of the men we've had to stop because the hemoglobin goes too high, because they get this really great, that may play into some of the quality of life. They just feel like they've got more energy because we get about a 6 or 7 point improvement in the hematocrit usually.
Yeah.
And what you learn is that as you learn this from depriving men of hormones, and you learn when you give it back, testosterone does a lot of things. It
does. It's amazing.
And not just the prostate, but the brain and the muscle and everything is involved. So some of those things get a lot better when you give it back. Some of them don't, but I think there's also an interesting inflammatory component that we're trying to understand. And
right.
We do see this flare that happens when we first give the testosterone. But we're trying to see if that actually could be something you could take advantage of with a kind of an immune therapy component. And the other trial that we're pursuing right now is, could we use this in conjunction with drugs like the radium drug? Because we do get a bone flare. Why not give radium with testosterone, where you might actually get more radium deposited in the bone and maybe a better therapeutic effect? So we just started a trial with a colleague down in Brazil, kind of with Brazil and Hopkins together. We're going to look at testosterone and radium together as in a small kind of pilot trial.
That's interesting. And radium also may have some effect on stem cells that people reported years ago that sort of got forgot. It's interest. One last thing, I know you're busy, Sam. It's so much fun talking with you. Thanks for doing it. Is that you mentioned, we talked about Abe Morgenthaler, and he has this theory of saturation of the androgen receptor at a low level, and a lot of things in life are U-shaped, too little, too much. What are your sort of thoughts about that, how that plays in this?
Well, I definitely think the prostate cancer itself, the receptor, there's a sort of a sweet spot that the cancer cell likes. So if you perturb it by depriving too much or over, giving too much testosterone, I think you move it away from, you have too much or too little activity. The saturation, I guess one of the things that we don't know very much about is what are the tissue levels and how much. So if we give, do we need a super physiologic level? It seems like we do based on what we know, but it doesn't quite fit in with some of this biology. I think it's probably that we're just driving more androgen into the cell where it needs to be by giving the high levels. That we're not saturating the microenvironment enough when we give kind of a lower level of testosterone.
Great. Sam, hey, it's been wonderful talking with you, and thanks for that presentation.
It's an honor. It's an honor to meet you and talk to you. I've really followed your work, and it's really been, your early papers were kind of part of the reason I got interested in prostate cancer in the first place. So it's really kind of an honor for me to talk to you.
Well, thank you for doing that. Tell my good friend Mario Eisenberger hi. And
I shall.
We'll have you back when you've got some new stuff here. It sounds pretty exciting, like you're going to have some more stuff very shortly.
Yeah, we have some good things cooking. So thank you.
Thank you.